Good afternoon, everyone, and welcome to today's webinar. Today's webinar on Aging in Place, New Approaches and Guidance is being held in collaboration with Healthcare Excellence Canada, HEC. And we are unveiling our new expert guidance on solutions to the pan-Canadian issue of aging in place, an issue that has garnered much interest and attention over the last few years. We are, in addition to launching our guidance today, we are having the team from Healthcare Excellence Canada share promising practices that they have been supporting around aging in place. My name is Sudha Cuddy. I'm Executive Vice President of Evidence Products and Services at Canada's Drug Agency, and I have the pleasure of being today's moderator. We are also pleased to share that today we are offering French simultaneous interpretation for this session. If you'd like to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. This session is being recorded, and a link to the recording will be shared by Canada's Drug Agency with all registrants later this week. Before we get started, I'd like to acknowledge that I'm speaking to you from our Toronto office, which is located on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. I'd like to acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Canada's Drug Agency recognizes the traditional territories, rights, and diversity of all First Nations, Inuit, and Métis communities across Canada. Indigenous people have been and continue to be excluded from and harmed by Canada's healthcare systems. In the spirit of reconciliation, we are committed to addressing these inequities alongside Indigenous communities. As part of our disclosure, I'd like to note that we are funded by the federal, provincial, and territorial ministries of health, except Quebec. Also, we receive application fees from the pharmaceutical industry for our reimbursement reviews, including those for oncology and non-oncology drugs and plasma protein and related products. We also receive fees for our scientific advice. We are excited today to have an engaging discussion with our panel of speakers who are here with us, albeit virtually, today. Dr. Jenny Basran is a geriatrician from Saskatchewan and a member of our health technology expert review panel, and she will provide an overview of the guidance and what it means for policymakers. Andrea Piché is a senior program lead from Healthcare Excellence Canada, and she will speak to the work underway at HEC and their promising practices, which are highlighted as part of HTERP's guidance. Chantelle Mensink, a nurse practitioner, and George Heckman, a geriatrician from New Vision Family Health Team, will introduce us to their specific promising practice as supported by HEC of an integrated care team for older adults in primary care. Following the presentations, we'll have approximately 20 minutes, hopefully, for a discussion with the audience and a Q&A, and we'll wrap up with some closing remarks. Please feel free to submit questions at any time by using the Q&A tab in the Zoom control bar at the bottom of your screen. And really, whether you've joined us today as a patient, a caregiver, an advocate, a clinician, an administrator, a researcher, health system leader, and or a decision maker, I'm certain you'll be able to relate to some of the insights and perspectives shared by our panelists today. And it's our hope that you will walk away with some new ways of thinking and approaching this important pan-Canadian issue. And finally, today's presentation will be posted to the Aging in Place website in both English and French when this session finishes. So let me just quickly frame up the issue. There's an important demographic transition in Canada toward an older and more diverse population, often with an increased need for care and support during the later stages of life. Aging in place is the ability of older adults to access health and social supports needed to live safely in their own home or communities for as long as they wish and are able. Health systems data indicate that more than 10% of new admissions to institutional long-term care are potentially avoidable with access to appropriate home-based support and care. There remains a strong preference by older adults to live in their home or community for as long as possible, while an estimated 7.9% of older people in Canada are living in long-term care facilities. Despite older adults' strong preferences to live in their home or community for as long as possible, health systems, health professionals, older adults, and unpaid caregivers are challenged to keep up with growing demands to provide and maintain available home and community care and support services at the level needed to support aging in place. In 2023, the federal government announced new long-term care funding for the shared priority to support people in Canada with aging with dignity, close to home, with access to home care or care in a safe long-term care facility. Tailored bilateral agreements with provinces and territories lay out the action plans to support people in Canada to age with dignity, and our work really complements and supports these action plans. So what did we do? Late last year, the Ministry of Seniors and Long-Term Care of Manitoba submitted a request to Canada's Drug Agency for gathering and analyzing evidence and information related to home care for older adults. Given that long-term care and aging at home are pan-Canadian priorities, we conducted work to support jurisdictions across Canada, including Manitoba, that are planning on implementing initiatives to improve home-based care for older adults. We explored the key reasons that prevent people from aging in place and provided an assessment of potential solutions to address these reasons. We also identified programs available in Canada, including the promising practices you'll hear about today from Healthcare Excellence Canada. We delivered a final evidence report in July. The Health Technology Expert Review Panel, called HTERP for short, used the evidence report to inform their deliberations and develop expert guidance for evidence-based approaches to support older adults to age in place for as long as they wish and are able to. This guidance was published at the end of August and is available on our website. And this is really the focus of our discussion today. We engage broadly with people who are aging in place or would like to care with caregivers, policymakers, clinicians, and researchers through the roundtable sessions. And the summarized findings inform the evidence review and deliberations. Just very briefly, what is HTERP? The mandate of HTERP is advisory in nature and is to participate in the development of guidance or recommendations for our projects on medical devices, diagnostic tests, and clinical interventions, inclusive of models of care, programs of care, and health systems. The committee is comprised of 7 core members, which include a chair, an ethicist, a health economist, a patient member, 2 healthcare practitioners, and a health technology assessment specialist. In addition to these core members, HTERP also includes up to 5 expert members appointed to provide their expertise on a specific topic. So for this particular topic of aging in place, HTERP appointed 2 expert members with expertise in caring for older adults, 2 expert members with clinical and healthcare administration experience, and 1 expert member with living experience as a caregiver. This guidance is intended for senior decision makers responsible for developing and implementing Canada's federal, provincial, and territorial policies and leading Canada's health systems, and the decision-making tables and teams who are tasked with advancing those health system priorities. I'm now going to turn things over to Dr. Jenny Basran, who's one of the HTERP expert members for this project, and she will walk us through the guidance.
Good afternoon, everyone. My name is Jenny Basran. I'm an internist geriatrician in practice for over 20 years here in Saskatchewan. I also serve as a senior medical information officer for the Saskatchewan Health Authority. As part of the HTERP work, I served as a HTERP expert member, and I'm pleased to share our guidance today. Before I get into the details of the HTERP guidance, I want to first explain that this guidance is broad. So it's a little bit different than what many people have seen for other types of guidance, in that it doesn't give a specific intervention. So it doesn't say, do these 5 things and you will solve the problem. And the main reason for this is that this guidance is meant to be pan-Canadian, and the issue of aging really is quite complex, and there's variation both within and across provinces and territories. So context is really important, and this differs between the different settings. So what we really wanted to emphasize is some key principles to kind of build the work that you want to do on aging in place, and then to work locally to understand the specific needs, what is the data telling, and then develop programs accordingly. Next slide. So HTERP's position begins with our our guidance begins with our position statement on aging in place. And the first is the acknowledgement that everyone has the right to age with dignity and in a place that aligns with their values and preferences. We appreciate that aging is just a normal part of life and that it can be accompanied for some people by changes in their health or their functional ability, including their ability for self-care. We know that some people may require assistance, whether for short-term or for others, it may be required long-term to allow them to age in place to maintain some of that independence. Older adults' needs change over time, as does what's important to them, and so should the supports that surround them. We also discussed how older adults comprise a heterogeneous population with really a continuum of healthcare needs and risks. They're not all the same. We can't group everyone into one cohort. And this includes people living with vitality, those with moderate complex care needs, and those with very complex care needs. And so some individuals are able to manage quite well with straightforward access to primary care or community supports, whereas others will need a much more complex approach addressing both physical, environmental, as well as social and psychological needs. So when we think about the healthcare system, here in Saskatchewan, in the 1940s when it was started, the median age was about 27. Median age is now 41. And so we know that there's some people that still manage quite well with what the system was originally built for. But the success story of medicine, as many of us say, is that people are living longer, they're surviving cancer and heart attacks and strokes, which is great news. But in that situation, as their needs change, we've been adding elements to that, but we've added those elements on the traditional foundation of the silos that have always already occurred. And we know now that that current model cannot adequately or proactively address the continuum of needs of older adults and their caregivers. So we really want to emphasize that aging in place is dynamic and complex. And while we talk about the health system, it is so much larger than just the health system itself and extends beyond that. Next slide. So a common and recurring theme that the committee really discussed that was important was the active role of the informal unpaid caregiver. This is what really allows for older adults autonomy and preference for their care to be realized. We also recognize that the population of Canada is diverse with a variety of cultural norms and values related to aging. And many cultures and communities may not even see aging as something that needs an intervention. It's really just a natural part of life, and that the belief is that it's common and appropriate for the families, friends, and communities to provide care. Lastly, we acknowledge that there are barriers to aging in place that disproportionately affect a number of equity-deserving groups, those that experience multiple and often intersecting historical, social, cultural, medical, structural, institutional, and environmental barriers to care and support. So HSHRP asserts that the health systems will achieve meaningful impact on aging in place outcomes if they implement continuous, integrated, team-based solutions that span the traditional budget and government silos of healthcare and social care. So an analogy that I like to use is a house having good bones. So when we think about a house having good bones, we know that it's built well, can withstand time and change. So whether we're building or buying a house, we want to know that the foundational structures are built in place, are well thought out, and are solid. And then from there, we can layer on the different elements depending on our preferences and needs. So the type of wallpaper we want, the type of flooring, etc., for both our current needs and then maybe future needs as things change. And so having a good system of integrated and connected care in places like having good bones. And then we can customize, adapt, and be flexible with what those services are built on, the older person's needs and the needs of the community. So the committee has provided guidance statements that kind of reflect this complexity of supporting older adults and their caregivers to age in place. The first one is to foster a system that prioritizes integrated models of care to address current and future unmet needs and bridge the gaps in and between services. So as I was talking about those good bones, the integrated model needs to acknowledge both the continuum of needs of the individual, needs to be flexible as needs change, whether temporarily or progressively, and we want to enable early intervention along with that continuity of care. So rather than building separate programs, how do we integrate? How do we not just focus on building capacity, but consider the flow and the movement of an individual between different programs? We also believe that the evaluation of the process and outcomes of implementing these models is really essential to not only know if we're having that intended effect, but also to make adjustments as we need. Because it's complex, you really will need to continually evolve and build your programs accordingly. It's also important that these evaluation plans reflect the complex needs of older adults, this flexibility and adaptability, particularly as the context changes. Our next guidance statement is to identify interventions that are aligned within an integrated model of care and are responsive to the unique and complex needs of older adults and their unpaired caregivers. So now you've got the foundation in place, you've got your house framed up. Now it's what goes in there. And this is where you really want to understand, what is your purpose? How do we build fit for purpose, make it adaptive, base it on data-driven understanding, what the local context and needs are. And critical to this is that older adults and caregivers have to be meaningfully involved in the co-creation of these models of care. The CDAMC evidence report that is attached has identified several interventions that we know have favorable effects, and they're also listed in the guidance report. We've also compiled the list of government-supported programs and initiatives will be found on the website. We also recommend looking at additional resources done by the National Institute of Aging and, of course, Healthcare Excellence Canada list of promising practices, which we'll be hearing more about. Looking at implementation, the committee acknowledged that the necessary changes are going to take time. They're complicated, and they will require an investment in education, training, infrastructure, and communication systems. We also outlined some considerations for older adults, specifically around facilitating the navigation and coordination of the available care and support in the community. We also highlighted the needs of unpaid caregivers, both the emotional impact and the additional supports required by them. Finally, consideration also for the needs of the primary care providers and the importance of coordinating this communication between and across older adults, caregivers, and care and service providers. Next guidance statement really focuses on ensuring that culturally appropriate and equitable opportunities are available for positive outcomes. We discussed the need of coordinating funding models to minimize the challenges that siloed or fragmented structures often put in place. Interventions to support aging in place should really be implemented with consideration of the inequalities that disproportionately affect members of equity deserving groups. Lastly, our guidance suggests to standardize core measures of indicators to guide data collection, analysis, use, and reporting that support robust evaluation and cross-jurisdictional comparison of interventions. We know that strategies that standardize and integrate both clinical and administrative data collection, the analysis and reporting is needed to improve interoperability. These are really key enablers to both team-based care and integrated care across the continuum. Then overarching data strategy then could support then the needs-based planning. So it allows us to know what the needs are as they evolve, and whether or not the outcomes are being achieved that we would like to see. So lastly, some key takeaways from HSHRP's guidance and what it means from a policymaker for policymakers. Given that the aging in place is quite complex, the committee's guidance provided several considerations for varying different types of contexts to consider. We highlight that fundamentally the system has to change to get meaningful impact. The system is meeting the needs well for some people, particularly those with less complex issues, but for a growing group of people with complex needs, it is not. A continuous, integrated, team-based approach is necessary for the growing population of older adults with complex needs. We also need to think beyond patients to caregivers, beyond health systems to social systems, transportation, and housing. Change is going to be hard, it's going to take time, but if we want meaningful change, we suggest considering the principles we've outlined in developing these strategies. Lastly, I'm going to say that there's no one perfect solution. I wish there was a magic bullet, but there's no one single perfect solution. We really need to look towards being integrated and flexible, build that foundation, use your needs, look at evidence to decide, what are the best practices that you can use to meet those needs, and including those identified by Health Excellence Canada's promising practices. And we also suggest you consider contacting the CDA AMC as a great resource to do specific evidence reviews on a particular strategy if you're thinking about implementing. In summary, consider the key principles that we've outlined to identify the need to be iterative, to understand the needs, to collect data, and to adjust as needed. Thank you.
Thank you so much, Dr. Basran, for taking us through the guidance. I love the house analogy, and that's going to stick with me. And I also love the recognition of the breadth of, moving beyond patients to caregivers, and especially moving beyond health systems to social systems. I think that is extremely important to note. So this time I'd like to now pass the virtual mic over to Healthcare Excellence Canada and introduce Andrea Piché. Andrea is a senior program lead at Healthcare Excellence Canada. Over to you, Andrea.
Thank you so much, Sudha. On behalf of Healthcare Excellence Canada, we're so pleased to join this webinar. And for those of you that we haven't met yet, I'd love to introduce you to Healthcare Excellence Canada. We're a pan-Canadian health organization that is shaping a future where everyone in Canada has safe and high-quality healthcare. And we do this in a number of different ways. We do this by partnering at all levels of the health system to find and drive the rapid adoption of quality and safety innovations, as well as through supporting people and organizations to build capabilities to enable excellence in healthcare, as well as catalyze policy change. So you can really see the bridge between CDA and Healthcare Excellence Canada, and how working together in the policy and implementation space will hopefully move us forward in important topics like this one. Go to the next slide. So HEC is currently leading work exactly on this topic that CDA's guidance is published on, and we're titled it Enabling Aging in Place. And our aim in this collaborative is to identify innovations that demonstrate evidence of important outcomes, such as delayed entry to long-term care, decreased emergency department visits, and improved quality of life, particularly related to social isolation. Go to the next slide. So through our collaborative, we are directly supporting 26 program teams from across Canada, and you can see on this map how they're distributed. And we're helping these teams on their implementation and evaluation journeys, while also continuing to identify and promote other promising practices that have already been implemented and are demonstrating impact. We have established a community of practice, and this is something that's open to all individuals and organizations that want to receive updates and opportunities related to aging in place and the work that's happening. And if you are one of those folks, we invite you to join the community of practice by just emailing us at the email that's shown on the screen. And I'm happy to also pop that in the chat in a little bit. For folks who have the recording of this, it might be easier to take that down. But we welcome all to join so that we can continue to move forward into the future as a community of people and organizations that want to improve aging in place for all Canadians. Next slide. So the promising practices that we're supporting and we're featuring in our collaborative, they all align with a set of program principles that we developed based on what was emerging from successful innovations. So we took a very strengths-based approach to look to see what were the common elements or threads in programs across the country that were all delivering an impact in this area. And not surprisingly, these principles highly align with CDA's guidance for aging in place. So the first two principles, they emphasize the importance of adding specialized healthcare services in combination with social and community support. And you'll see evidence of this combination of services in promising practices featured on our webpage, such as the Nursing Home Without Walls program, the Community Paramedicine at Clinic program, as well as many others. And of course, CDA's guidance speaks clearly to these two principles in its recommendation to provide integrated models of care that include supports for both the health and the social system, which is what we're seeing in things that are going really well. And in addition to providing health and social services, another key principle that we're seeing being lifted up in really successful innovations is providing appropriate service navigation and coordination, or accompaniment, as it's sometimes called, on the journey to accessing and receiving services. And we've seen these services and programs that are anchored to many different areas of the health and social continuum, including primary care, social housing, long-term care, and most often in community organizations. And what we know is that in many cases, the role of that system navigator or coordinator is filled by an unpaid caregiver. And they're trying to navigate across silos of health and social and community care, often while maintaining, full-time commitments of employment, caring for children. And so the need to reduce the strain on caregivers is something that will really support aging in place. And again, something that CDA is speaking to directly in their guidance as an important measure for reducing caregiver burnout, which the data shows, as we know, is a primary barrier to aging in place. So the final three principles go beyond describing the types of services that are needed, what has to happen, and really outlines the importance of how we're providing these services. So recognizing that a person's needs, goals, preferences are dynamic over time, right? The complexity of care changes. We need approaches to support aging in place that are adaptive and responsive. And ensuring that all community members can equitably access safe and culturally appropriate healthcare and social care requires consideration of social and structural inequities and principles of distributed justice. And finally, providing high value care to enabling aging in place requires responsibly, respectfully, and creatively partnering to leverage existing health, social, and community resources. And so all of these value-oriented principles, as we refer to them, have been highlighted in CDA's guidance, and you'll see them all in the promising practices that HEC is curating, and we're continuing to curate and post on our website as time goes on. I think I can pop over to the next slide. So if you want to know where to find these promising practices, there's many of them, and again, they span the health and social continuum. They are on our website, which is shown here. And thinking ahead in terms of wanting to spread and scale these promising practices, what we're going to need going forward is jurisdictional partners who are willing to support the implementation of these in concert with HEC's resources, our capacity building tools, our communities of practice to help guide those implementation efforts. And we need this to be supported by policies that are informed by CDA's guidance. And I think when you put that together, we have a strong recipe for how we can advance these promising practices into the future. And so I'm really pleased to turn it over now to Chantelle Mensink and Dr. George Heckman from New Vision Complex Care Program in Kitchener-Waterloo, Ontario. They're going to be our newest featured promising practice. Their write-up is coming very soon. And so they have brought with them some inspiration of what's possible when you align the right combination of resources to meet the needs and challenges of complex care in the community. So I'd love to hand it over to you folks. Thank you.
Hi, thank you so much for having us. As Andrea stated, my name is Chantelle Mensink. I'm a nurse practitioner at the New Vision Family Health Team, and I'm going to be talking about our complex care program that we've been running out of New Vision. Next slide, please. So we started the complex care program at New Vision in about 2017 after we recognized that many of our complex older adults were coming to many of our disease-specific programs. So they were coming to our congestive heart failure program, our diabetes program, our memory clinic. They were seeing their primary care provider. And this was really resulting in very fragmented care and was quite cumbersome for the patient and the caregiver. And so what we did instead is we created the complex care program, which is a program that meets the entire needs of these patients and their caregivers. So we certainly manage their medical needs. So we'll help with their diabetes, their congestive heart failure management. We certainly help with patients with expressions related to their dementia. We work with caregivers. We are system navigators. My team always teases me and says, "What hat do you have on today? Your medical hat, your social work hat?" We really try and make this program meet the entire needs of these patients. So this team is a multidisciplinary care team. It's a shared care model. It's a case management approach to care where we follow these patients ongoing. It's NP-led. We have RNs and pharmacists, and we're also supported by a geriatrician and a geri-psychiatrist who actually come and see patients in our primary care setting, and they're directly embedded into our EMR system. And this really allows for them to have access to all of the patient's social and medical history, which really helps in the overall care for these patients. And as as you can see here, these patients are quite complicated. They're high users of the healthcare system. They often have multiple comorbidities. Some have, poor social support system. And so we're really working with these patients to help keep them out of hospital and out of long-term care, sooner than they need to be. Next slide, please. So then in 2020, 2021, we received some temporary funding from OH West to expand this program out into the community. We recognized there was a high need in our community. People were waiting about 18 months to see a geriatrician. And so we really wanted to step in to help with that. And so we were able to embed ourselves into 4 other primary care offices. So that covers about 40 primary care physicians in our city that don't traditionally have access to a multidisciplinary care team. And again, we're directly embedded into their electronic medical records. They have access to our full team. So we go on site to see them, or they might come to our clinic here if we really, let them choose. And as part of this expansion, we also started working very closely with our community partners. So as mentioned earlier, there is these silos that exist in our healthcare system. We have our primary care, our community, and our acute care setting, and there really is not a lot of communication across those silos. And we recognize that as a big problem, and we wanted to break down those silos that exist in care. And so what we do every couple of weeks is we meet with our community partners. So home care is there, paramedicine's there, we have hospice there, we have our Behavioral Support Ontario colleagues there, and we really work together to look at these patients. So we look at new referrals together, and we really decide who makes sense to see this patient. It might be the geriatrician, it might be myself, the nurse practitioner, but it also might be the occupational therapist. It might be our RN who has a specialty in mental health. We really try to figure out who makes the most sense to see this patient so that the patient is getting timely access to care and they're seeing the most appropriate provider. The other thing that we do is we also accept referrals from the community. So we get referrals from the hospital, the gem nurses. We get referrals from Impact, which is a social work team with the police. We accept referrals from all over the community. We also take unattached patients. And so we're really working towards spreading this program into the community so that we can help meet the entire needs of all of these patients. Next slide, please. So you can see here, this is our process map, and I'm just going to point out a couple key things on here. One thing that we do is when a patient is referred to our program, we ask that they complete 2 inter-eye tools. One is called the inter-eye checkup, and one is called the inter-eye scan. And these tools, one is done by the patient and one is done by the caregiver. And so the one that's done by the patient, it gives us a ton of information. So it talks about pain and falls. It talks about their cognition. And function, a lot of information. It also gives us some outputs. One of called the assessment urgency algorithm. So it allows us when we're meeting together as a community with our community group, we can figure out which patients need to be seen. So it allows us to risk stratify patients. But the other thing that's really important for us is that when patients come and see us, instead of asking all of these history questions over again, which many patients say they tell their story a million times, we're really able to see them and have these really meaningful conversations. We can ask them, what's going on with you? What are your goals of care? And how can we help meet those goals? The scan is actually done by the caregiver. So we recognize that, caregivers are tremendously important in our healthcare system, especially for our older adults. And so we ask them how they're doing. So they fill out this tool that's specifically asking about their needs. And then we work to implement resources for the caregivers as well, so that we're, providing education opportunities. We're connecting with the Alzheimer's Society or the Ontario Caregiver Organization for education, maybe asking for some more respite time. So really trying to meet the entire needs of this family. I think the other thing I wanted to point out on this slide is that we really do offer a case management approach to care. So these patients might see us, they'll see us for the initial consult, but then we follow them ongoing. And I think a big thing that is important for this community is that they're getting that ongoing care because their medical needs ebb and flow all the time. I might go a couple months without talking to a patient, and then I may talk to them once a week for a period of time because their needs are continuously changing. And the patients have direct access to to us. So they have our extension, they can message us, we'll see them in clinic, we'll see them at home visits. We try to be accessible as possible so that we're really trying to keep them out of hospital and keep them well supported in their home. So as the topic for today is that they can age in place for as long as possible. Next slide, please. So you can look here, these are a little bit outdated. We're just looking at pulling our new numbers, but you can see here that 100% of people that we surveyed were satisfied or very satisfied with their experience. They felt that it made them more confident in managing their health. And you can see we made a lot of referrals to our community partners, and many people felt like the program was very, very beneficial. So I'm going to pass it over to Dr. Heckman to talk a little bit more.
Okay, thank you. Thank you so much. As mentioned, I'm a geriatrician, and I guess most geriatricians as specialists will work in some sort of hospital-based setting or a clinic setting or a teaching center. But the bulk of my clinical work is in a family health team. And I don't provide primary care, but it's a lot easier to provide more proactive care working in a primary care setting where we direct people to. As a geriatrician, there are some very important efficiencies we can talk about as well in terms of my workload versus my ability to see more patients in this kind of setting. And so one of the ongoing challenges for any community-based program is to provide data to not just peer-reviewed journals, but we want to provide data to funders. And that's an interesting challenge that Health Excellence Canada is very helpful at people like us at trying to develop and meet. And so part of our initial funding was through a grant from the Advancing Frailty Care in the Community that was a Health Excellence Canada and Canadian Frailty Network initiative. And so they've been very instrumental in helping move this work forward. And so while we want to recognize that we are wanting to do more in-depth analyses, we did conduct a preliminary economic analysis, and we basically avoid $5 of healthcare spending for every dollar spent on this program. And this is achieved through a variety of measures. Overall, excuse me, overall patients in this program have about 15 to 20% fewer visits overall because they come to one visit and multiple needs are assessed. In addition, their family physicians are able to not offload to the team, but they share the care with the team, and therefore the family physicians, who we know are in shortage across the country, have more time to see other patients with more acute needs. As the geriatrician, I don't have to do as many follow-ups, and so that way I'm able to open up more spots to see more patients. And so there's an efficiency there. But from a health system utilization perspective, there are a number of patients who've gone through our program who have either died in a hospice rather than go to a hospital, and many people have died at home rather than in a long-term care home because we were able to anticipate eventually these people will experience a demise, but we're able to plan this and avoid hospitalizations and promote either dying at home through palliative care or through hospice palliative care services. The further cost avoidance relates to the initial assessment where we showed that people in the program, comparing the year before the program to the year after they would join the program, they had a 50% reduction in visits to the emergency department. And some of our ongoing work in terms of the newer referrals, we are avoiding about 70% of emergency department visits. So many of these physicians, knowing that we are there, will refer to us rather than send people to the hospital. Some of the geriatric emergency management nurses, again, have caught wind of our program and in many situations are now referring community-based patients, often unattached or often physically unable to get to their family doctor, to our program, and thus diverting people from the emergency visits. And so essentially, the cost avoidance is achieved through a variety of these outcomes. Next slide, please. we have a paper now been submitted, but essentially this was the initial analysis of the program when supported by the initial advancing frailty care in the community. And it gives you an idea of the type of patients that we see. So the patients in this initial evaluation were about 82 years old on average. 70% are women. And so we know that women are more likely to be frail. About half of people had a certain degree of cognitive impairment. And on average, they had 90% of them had 3 or more chronic conditions. So multimorbidity is extremely common. And as you can see, 13 prescriptions daily, these folks were receiving. And so not only do we help with the chronic disease management and alleviating the caregiver burden, but we also have all of these folks referred by a clinical pharmacist, which is an essential role here. They all get a medication review, and about 95% of people in the program will have some changes to their prescribing, often deprescribing of psychotropics, benzodiazepines, non-steroidal anti-inflammatory drugs, things that make you dizzy and sick to your stomach and fall. But we also find that a lot of pain is undertreated, and so people are prescribed proper analgesia. A lot of cardiovascular medications are underutilized for heart failure and hypertension, and these are optimized. And bone health is a major focus, with a lot of people being screened for fracture risk and then treated for fracture prevention. And again, the satisfaction with care among the patients, their care partners, and the referring physicians is high across the board. Next slide, please. At this time, we are, and I think that's one of the challenges in terms of sustainability, and we're grateful for the funding from the Ontario Health Teams, but the funding is year over year, and I mean, one of the things that does need to happen is, and that's why the work that Health Excellence Canada and you are doing to highlight best practices is essential, but it does take time for teams to gel. There's been some excellent evidence in the US where teams have taken 2 to 3 years before they start achieving their outcomes. And so funding is always a challenge, but I think the opportunity here to discuss these application of these principles from the technology assessment, that these things are doable and realizable and do achieve better outcomes for patients and contain costs is a very important opportunity. Next slide, please. Okay, that's it. Thank you.
Great. Thank you so much to all of our panelists for an engaging discussion. We have lots and lots of questions, so I'm just going to dive right in and start asking some questions. So I think the first question I'm going to ask, I'm going to pose to Dr. Basran. You know, given Canada, the breadth of Canada's geography, how can this HTERP guidance apply in urban communities as well as to caring for older adults in small rural communities?
Yeah, thank you for that question. I actually grew up in small town Saskatchewan, so a town of about 500 people. So it's always near and dear when I think about the work that I do. And I think that in our guidance, we had a lot of discussion around particularly the geographical challenges that people would face and the impact of the team-based care. And so we know it's challenging to get resources, a full scope of resources out in some of these communities. However, I think there's 2 parts to it. From a clinical perspective, we do have, you know, advancements in technology that allow us to do great things like this, where we can all gather together and do, you know, team-based rounding, team-based care that's virtual, particularly if you have supports on site. A key component to that is ensuring that we're building capacity in the local context as well, so that it's not about deferring care away, but building care, building kind of competencies and understanding of how to manage individuals and their needs. The other part really is the broader scope beyond the health system. So, you know, often in conversations I will have with patients and families is, you know, should mom move in? She wants to stay in her smaller community, but, you know, we feel better if she moved to the city to be closer to us. And we often have conversations around the supports of that, of you know, what's supporting that individual there, and how can communities build those up? So how do you take your local communities to build social supports, ways to engage in physical activity, things like that? And I think smaller communities in many ways are better adept at doing that, and it's really around providing some additional support. So Health Quality Council in Saskatchewan is doing some work right now that really, in partnership with Health Excellence Canada, to really bring together communities to say, how do we know what each other's doing and work together to build resources and opportunities to support others. So I think there is a way, but it needs to be coordinated. I think individually trying to solve small pieces of the problem is very challenging, but together we often can do a lot more and share a lot of the learning and resources.
Thanks so much. The next question is a little bit of a tag onto the earlier one and a thread that you were just sort of answering. And I'll ask Chantelle this question. You've described how a comprehensive framework will require change management, investment in education and infrastructure, while interconnecting elements to meet a range of needs. Where do you see the largest opportunity for patients, community groups to engage as various organizations align in building this positive future? So in other words, how can patient and community groups get involved and help partner in this work?
Yeah, that's a great question. George, you might be better to answer this than me, I wonder. Yeah, George, you want to take this one? Oh, you're on mute.
Sorry, I was answering something online, so I'm hoping you could repeat the question. I'm sorry. There were some Q&As online, so I was focusing on that.
Yeah, the question is really, how can community groups get involved in helping with building this future?
Well, I think, and again, that relates to one of the questions that was asked that I was answering, is a lot of this has to do with self-care and self-care coaching. And, you know, part of the success of things like heart failure clinics in terms of not just improving outcomes, but also ensuring that the clinical team is offloaded as much as possible so they have the capacity to see others, is working with people to understand how to support their own care. I think one of the things that is now emerging in the literature is the notion of naturally occurring retirement communities. And that's an interesting approach, because where there are clusters of, say, older persons or persons with chronic health issues, sometimes the community support services can go out there and start doing home visits. And neighbors with expertise in this or that chronic illness can start helping themselves. And so there's very good examples in New York City where, again, these clusters take place. The people in the apartments start to self-organize. They get guided by health community support, such as public health nurses, and primary care clinicians can then go out there. I think what we might want to think about is trying to make that model more understood widely where we are, but also to start having cities and urban planners start thinking about creating spaces where you can have this kind of work. You know, if you have high-rise condos with 500 square feet, that doesn't necessarily lend itself to that. So we want to think about the urban infrastructure, but I think, you know, we need to make people aware that this is something that's very useful, that is showing extremely useful promise, not only New York, but now areas of Toronto, where essentially we can work with the community to enhance their self-care skills, which is always better outcomes for them, but also, you know, we are in an era of shortage of healthcare resources. We can't do this for everyone, and we need to stop, but we don't have to. You know, if we can change the conversation and help people help themselves, and as Chantelle mentioned, be available when that inevitable exacerbation happens, because these are chronic illnesses. There's going to be a crisis at some point. And the program that we have helps intercept that before it leads to more complicated problems. But I think this is a very hopeful and interesting model for the future.
Thank you for that. And Chantelle, maybe I think this one is right up your alley. It looks like the NP is the quarterback of this model. Yay, NPs. How manageable is the NP workload? I'm thinking about NP turnover and that impact on the model.
Yeah, so I think that is a really important thing to consider. I also think it's important to have conversations with the leadership team about expectations for this program and how many patients you can truly roster. So, I know in a lot of situations or a lot of different programs, there's sort of this magic number of we want NPs to roster about 800 to 1,000 patients. That's not realistic in this program. These patients are very complex, and we are talking to them all of the time. They're high users of the healthcare system, and so we're constantly involved with them. So I think it's important to have these conversations ahead of time to set a number that's realistic, and that does make it manageable. But I think the other thing that makes it manageable is it's not only on me. I have an entire team. So when I am working with a patient and I know that this situation is more medication related, I'm going to pass it off to my pharmacy colleague and say, hey, you know what, can you, manage this patient for a little while, and then I'll get sort of back involved as needed. If it's more of a mental health or a social need, our registered nurse is fantastic at that stuff, better than me. So she'll go out and manage those things. If it's something that I feel a little bit beyond my scope, or I just need a little bit of guidance around, that's where I might reach out to Dr. Heckman. So I think, again, we need to really focus that this is a shared care model, and it doesn't all have to fall on one person. It's really about working together and figuring out who is the most appropriate person and to see this patient. And it doesn't always have to be me. It doesn't always have to be Dr. Heckman. So I think those two things, is having realistic expectation and really participating in a shared care model, can help reduce that burden.
Thank you. Question for Dr. Basran. You touched upon the importance of having small communities to enable individuals to stay active. How do we focus more on preventative programs rather than sort of on, downstream effects due to illness? So how do we encourage governments to invest more into preventative programs and incentivize healthy living and perhaps penalize bad choices? They gave the example of the sugar tax in the UK.
Yeah, so, certainly prevention, for geriatricians, and I think George would agree that, the span of what we're talking about, we focused a lot on really complex care, but we know the best thing we can do is to prevent that, whether it's preventing chronic diseases from occurring, preventing exacerbations, but also just the well-being and strength. So the physical activity is a really important part. And I think that's really where that understanding the unique needs of the community. So what are the opportunities where you can get people out that allows them to stay active while engaging in perhaps social activities and other things that are enjoyable, intergenerational opportunities, things like that. I think when we've been talking to some local RMs, we have encouraged them to say, if you're building a rink, put a walking path around that rink and think about what else can we do? What other programs can occur? Are there some spaces that we can add in that allow people to engage with others while they're doing that? And that allows those opportunities. There are individuals who may not want to go out and be around a lot of people. So also having some opportunities for, the In Motion program and other programs out there that really encourage that piece of it is important. And so we, again, I think, Healthcare Excellence Canada and others have been really working on trying to look at social prescribing, and part of that whole bigger picture includes that physical activity and well-being. And I would highlight again that I think that, having seen this and done this for a long time, individual programs, individual groups advocating for funds, it's really challenging because you're competing against other groups who also have lots of great ideas. So really this idea of working together and thinking, this is a need that we're trying to address. This is a need we're trying to address. Another group is doing this, but the three of us coming together to provide a bigger basket of opportunities, both gives you strength in your application for that funding, provides a much bigger kind of basket of opportunities, and is often much more applicable and relevant to the local community. So I would encourage taking those types of approaches. And again, we have links on the website and others for resources and programs that are currently available as well.
Thank you for that. It strikes me that this is one issue that spans across different levels of government, not just federal, provincial, but as municipal as well. And so really everyone has a bit of a role to play in supporting aging in place. I think with that, we're going to draw this webinar to a close. Lots of great questions, lots of great engagement. Really want to thank the panelists in the audience for attending today's event. A huge thank you to Canada's Drug Agency and a special shout out to Gino and Laura and the entire team for drafting an exceptional report, and to our health technology expert review panel for crafting guidance that we're hoping will really help all of you in the field as you look towards supporting aging in place. And part of our hope for really tackling this broad, complex issue is that we've been able to share information on relevant interventions, such as the one that you've heard today. That could be a starting point. We encourage you to share this work with your networks, and after this event, we'll be sending you a link to the recording on the YouTube channel. And again, these slides will be posted on our website in English and French. So if you have a few moments, please fill out the post-event survey, which will open in a new window when the webinar ends. Here is a barcode, one of these scanny codes, you know what these things are called, it's just slipping my mind right now, where you can stay up to date with our latest work by subscribing. A QR code, that's what it is, by subscribing to our newsletter. And so just scan the QR code and you can subscribe to the dispatch, where you'll learn about these types of initiatives as well as many others. And last but not least, please feel free to connect with us at any time on all of our social media all of our social media channels. And with that, thank you again all for joining us. Thank you so much to our panelists for sharing your knowledge, your expertise. I feel like with the number of questions we received, we could talk for another hour on this topic, but really, really appreciate all of you taking your time today and for joining us and engaging. Thank you and have a great day. Take care.
Thank you.